I want to begin by asking the members of CEPAC to introduce themselves. Begin with our Vice Chair, Jason Wapsie.
Good morning. My name is Jason Wasby. I'm an assistant professor at Harvard Medical School. I'm a cardiologist at Mass General and medical director of the Physicians Organization, and I have no changes to my disclosures.
Good morning. My name is Stephanie Nichols. I'm an associate professor of pharmacy practice at UNE College of Pharmacy, faculty at Tufts School of Medicine, and a psychiatric pharmacist.
Good morning. I'm Steve Kogut. I'm a professor at the College of Pharmacy at the University of Rhode Island, where I direct our graduate program in health outcomes research.
I'm Ed Westrick. I'm an internist here in Rhode Island and a former pharmacoeconomist.
Good morning. Sorry to have my back to you all. I'm Jason Schwartz. I'm an assistant professor of health policy at the Yale School of Public Health.
Good morning. I'm Martha Gold. I'm a senior scholar at the New York Academy of Medicine and a family physician and a public health person by profession.
Good morning. I'm Greg Lowe. I'm the director of the Mass General Physicians Organization's Pharmacy Quality and Utilization Program and a pharmacist at Mass General Hospital.
I'm Brian O'Sullivan. I'm a pediatric pulmonologist at Dartmouth Medical Center and Geisel School of Medicine in New Hampshire.
Good morning. I'm Lefteris Milonakis. I'm a professor of medicine here at Brown, and I direct the infectious disease division also.
Good morning, everyone. My name is Leslie Oakes. I'm an associate professor and chair of the Department of Social and Administrative Pharmacy at the College of Pharmacy at University of New England.
Good morning. Claudio Gualtieri with the AARP Public Policy Institute, a senior advisor working primarily on issues impacting healthcare access and opportunities for building a culture of health. Thank you.
And I'm Rob Azeltine, professor and chair of the Division of Behavioral Sciences and Community Health and director of the Center of Population Health at UConn Health Center. At the beginning of every New England CEPAC meeting, we want to make sure that all of our speakers and participants disclose any conflicts of interest with the health industry. All the members of the CEPAC panel today have met ICER's conflict of interest policy. I'd like to give everyone an opportunity, I know Jason did that, but to update those conflicts at this time. And I do have one update to offer as I served as a consultant to Merck's Center for Outcomes Research related to vaccine confidence. At this point, I'll introduce Dr. Steve Pearson, president of ICER.
Thank you, Rob. Good morning, everybody, those here and viewing it via webcast. Thanks for coming. Today is November 14th. I think it was at least a year ago, before we even knew we would be doing this topic, we decided to pick the date for this meeting that happens to be World Diabetes Day. We knew it. We just saw it coming. Anybody know why World Diabetes Day is November 14th? Google does. You do.
Happy birthday, Dr. Banting.
That's right. Frederick Banting, one of the co-discoverers, inventors of insulin. Some people love to point out that he went on to give his patent for insulin away for $1, because he felt it was unethical for physicians and others who developed treatments that could help a lot of patients to benefit from them financially. We do not live in that century anymore. We have many more treatments for diabetes. The reasons that we are here today are because despite the almost a century of advance since the discovery of insulin, there still remains a tremendous patient burden with the illness, growing in many ways in our country and around the world. You'll hear from others what we've learned from patients throughout this process, but a couple of quotes to kind of set the stage. One came from a patient and it said, "It's really hard to live with diabetes. I have to watch what I eat, and I'm worried that my arms and legs and feet will never be back to normal. Only muscle relaxers make me able to walk. I will do anything to try to prevent the damage." Another patient reflected on what it's like to be diagnosed. "When I was diagnosed in 2016, I immediately felt discouraged and like I wasn't being heard. I was handed a few bottles of medication and insulin without much explanation of what they would do and told to come back in 3 months without understanding my targets or even how to take an insulin injection. Naturally, I failed." Notice how she feels like she failed. My A1C barely budged, and I was frustrated about having diabetes without much guidance. So we're here today because we are continuing to fail the patient population with diabetes. As a lapsed primary care provider, I can honestly remember one of the worst feelings I had was rendering a diagnosis of diabetes to someone who didn't know they'd had it. It created unbelievable stress in their life and confusion. I thought our healthcare system, myself included, was woefully inadequate at helping them cope with it and understand what the options were, what to do with their daily life, what they could eat. I mean, it was a mess. And I think we've gotten better, but I think we will also be able to hear today ways in which the system has a lot of ways to go. So we'll be talking about drugs, but I know that there's a much larger context for the treatment, diagnosis and treatment of patients with diabetes in this country. And I hope that our work can fit within a broader context of improving those aspects of care as well. So in terms of the drugs that we will be talking about, one of the reasons we're here today is because when a new drug is approved, again, patients and clinicians often celebrate the innovation, another option. Sometimes that will mean really important benefits for patients because of the different side effects or different convenience factors, other things, benefits, harms. What also happens that day is that the company gets to name its price. Now, this is a very kind of crowded area, lots of different potential drug treatments for diabetes. So there's obviously competition, but there's still amount of struggling to understand the early evidence as drugs are launched. We have to make coverage decisions across payers and pricing decisions. And so a lot has to happen relatively soon after FDA approval. So one of the reasons we're here today, even though it's obviously early in the evolution of evidence on any new treatment when it's first approved, is because a lot of questions will be answered in the short term with decisions that will have a lot of weight going forward. So we hope that today's meeting can improve that. Historically, what happens is sometimes, again, people kind of fluster around. There may be a lot of requests for a drug. Sometimes insurers don't have good systems for early access. Again, there are sometimes stress for patients in terms of the costs. So that's the challenge we face today, is to try to build a bridge between what we know today in the short term to an approach to building clinical practice, education for patients and families, and pricing and coverage that will best meet patients' needs. So the goals for today are to do that. You've already met the members of the New England Comparative Effectiveness Public Advisory Council. I also just realized today it's not their birthday, but it is the 10th anniversary of the New England CEPAC, ICER's first public advisory council. So Rob, yeah, we're all 10 years older. Hard to believe. You don't look a day older though, Rob. You really don't. You really don't. The academic secretariat, if you will, for this process is ICER. So just a couple words about us and the report itself. ICER is an independent, nonpartisan, and nonprofit research institute based up the road, I guess, in Boston. We keep a pie chart updated on our website for our funding sources. You can see the biggest blue chunk there is from nonprofit foundations. The primary funder within that group is the Laura and John Arnold Foundation. We also receive funding from the California Healthcare Foundation, from the Commonwealth Foundation, and the National Institute for Healthcare Management Foundation, among a few others. You see that we do have direct contributions from health plans and provider groups and from drug manufacturers. That goes into a separate bucket, if you will, to help fund a policy summit and other activities of convening among leaders in those organizations, and is not used to support the research conducted as part of these reports. So to try to briefly describe how the report was developed, we start with a scoping phase where we talk a lot to patient groups and clinical experts, obviously the manufacturers, and other stakeholders, just to try to make sure that we understand what matters most to patients, what are the different elements of diversity that we need to remain aware of as we look at evidence that's usually gathered, obviously, on groups of patients. And then once we've kind of tried to figure out our key questions and where we're going to be wary of different things about the evidence, we go to do a full-blooded systematic review of the evidence, both that which is already published and that which we can get either from manufacturers or from other sources to help complement our work. Simultaneously, there's a cost-effectiveness modeling effort that in this case was handled by faculty from the University of Washington. You'll meet them later. We go through phases of public comment and input and revision, and we have formal expert reviewers, 2 of whom will be with us here today. They include Samar Havita, Joanna Mitri, who's just arrived, and Lisa Murphy, and we'll be introducing you to them again soon. Please, yeah, feel free to come on up. So how's the evidence itself? I do have a slide it's in the packet that people can look at. This is a timeline for how our reports happen over about a 7.5-month period. Again, as I mentioned, with scoping, phases of public input and revision before we get to a final report. That final report is structured in a way, and the conversation today is structured in a way that reflects our approach to discussing value. So just briefly, this is our value assessment framework. We start with a goal, the goal of fair pricing, fair access, and future innovation that we think that all stakeholders in the healthcare system share commonly as a goal. And in our reports, we think that for decision makers, especially at the population policy level around pricing and coverage, that they need to understand information around the long-term value for money and the short-term affordability to get to that kind of tripart goal. Now, long-term value for money is itself a kind of a composite concept. And in our reports, we provide information on comparative clinical effectiveness, and you'll hear that information today. We obviously talk about incremental cost effectiveness. We also will discuss the other potential benefits or disadvantages that might lie outside the evidence gathered in clinical trials and other sources, but which may still be very important in thinking about the value to patients and families and the system, as well as contextual considerations around the severity of the illness, the availability of other treatments, those kinds of things that factor into broader judgments around value. For short-term affordability, our reports provide a potential budget impact tool that allows end users to kind of put in their own assumptions around what the uptake is likely to be and at what price, and you can kind of see what the national potential budget impact would be, taking into consideration whether there are cost offsets from treatment that we should be aware of. So with that being the framework for the report and to a certain extent the discussion today, the agenda will flow with beginning with presentation of the evidence. We will then have manufacturer public comment and discussion and public comment and discussion, followed by lunch. And do we have lunch for the visitors today? Okay, so lunch is available for visitors probably downstairs or around the building. Follow the students at noon. You'll find where the lunch is. We'll come back at 1 to do the further deliberation and voting on questions around comparative effectiveness and value. Then following a short break, we'll have a policy roundtable discussion. And that's where we will really try to take what we've learned about the evidence and made judgments about it, and then pivot a bit to talk about how we will think about applying that evidence in the design of coverage, of pricing, of future research, to really, again, kind of look downstream at the ways that we can use this evidence to try to meet that 3-part goal. And we will adjourn by 4 to make sure that people can get on their way into the lovely New England traffic. We are very glad and appreciative of our clinical and patient experts throughout the process and those who join us today. Could I just invite each of you to introduce yourself briefly? And if you have any potential conflicts of interest with health plans, industry, or others in the health system, please let us know.
Hi, I'm Elizabeth Murphy, or Lisa Murphy, and happy to be here. I have no conflicts of any kind around this, and I'm a professor of clinical medicine at UCSF and also the chief of endocrinology at San Francisco General, which is our public hospital.
Good morning. My name is Joanna Mitri. I'm an endocrinologist at Joslin Diabetes Center. My conflict of interest, I do research and speaking and consulting for the National Dairy Council. Beside that, just research for COA and NIH. I chair our clinical practice guidelines at Joslin, so always interested in looking at these sort of documents.
Thanks, Joanna. Susan?
Good morning. I'm Susan Weiner. I'm a diabetes care and education specialist, certified diabetes educator, and registered dietitian in private practice in New York. And I am here representing as a clinical advisor on the scientific advisory board for Beyond Type 2 diabetes. I'm also on the advisory board for Beyond Type 1.
And thank you again very, very much. So they serve as a resource Throughout the day, during the morning when the evidence is being discussed, they can be helpful sometimes in giving some perspectives to that. And then they will also participate quite actively as we deliberate and vote and then move to the policy roundtable. So thanks again. All right, with that, let me introduce Dr. David Rind, ICER's Chief Medical Officer, who will lead us through a brief overview of the evidence on the clinical effectiveness of the drug under review today, and we'll take it from there. David?
Good morning. I just want to mention key collaborators who are here, Catherine Fazioli, who research lead at ICER, and Eric Borelli, evidence synthesis intern at ICER, and we have no conflicts of interest. So diabetes, incredibly prevalent, 30 million people with diabetes, 95% of those have type 2 diabetes. For all diabetes, estimated annual costs in 2012 were $245 billion. Estimated hospitalizations in 2014, 7.2 million. What's diabetes? So if you think about the word diabetes mellitus, that translates essentially to excessive sweet urine, a symptomatic condition with weight loss, electrolyte abnormalities, death. But in type 2 diabetes, you have many patients who don't have increased urine, increased sweet urine. Many of those patients aren't spilling sugar. The A1C has to get to close to 9% before you hit the blood sugar levels of 200 milligrams per deciliter, where you end up with glucose in the urine. And so many patients with type 2 diabetes are asymptomatic. So when we think about type 2 diabetes, it can be a condition with symptoms from very elevated blood glucose, but for many patients, what it is really is a risk factor. It's a risk factor for macrovascular disease, coronary disease, cerebrovascular disease and stroke, peripheral vascular disease, including claudication, infections, amputations, and for microvascular disease, renal disease leading to end-stage kidney disease, retinal disease leading to blindness, neurologic disease causing lots of problems with numbness, injury, infection, and chronic pain. So when we're talking about diagnosing and monitoring diabetes, we have diabetes defined by measures of blood sugar, fasting blood glucose above 126 milligrams per deciliter, or an A1C greater than or equal to 6.5%. And then those same testing methods can be used to monitor treatment effectiveness. But there's surrogate outcomes in asymptomatic patients with type 2 diabetes. You could have a therapy which decreases glucose and yet increases risk, or increases risk factors such as weight. And you could have a therapy that doesn't lower glucose as much as another therapy, but decreases the patient-important outcomes. And this was driven home to people by the thiazolidinediones and concerns that were raised about increased cardiac events, some of which, like MI, probably aren't so much associated with them, and others, like heart failure, that probably are. But this really highlighted the issue of the surrogate nature of these measures in type 2 diabetes. So in 2008, the FDA mandated cardiovascular outcome trials, CVOTs, with hard endpoints for new anti-diabetes treatments. The intent was really to ensure that these agents were safe, that they weren't increasing the risk the way it was felt at the time thiazolidinediones might have. But the result was that some agents that were found to lower A1C were lowering patient-important outcomes even more, out of proportion, even though that wasn't really why the CVOTs were started. So what does it mean to have type 2 diabetes? For many patients, the initial impact is around being diagnosed and treated. You have the fears that we've just heard about, you have frequent testing, multiple medications, the costs of therapies. But over time, the severe macrovascular and microvascular complications of diabetes come to dominate. For management of diabetes, in the US at least, first-line management and probably everywhere, first-line management is based on lifestyle changes, increased physical activity, changes in diet, and then first-line medication in the U.S. is typically metformin. Metformin doesn't lead to weight gain, and it doesn't lead to hypoglycemia when it's used as a single agent. And then you have a lot of additional options. I've put in bold here the ones that are showing up in this report in some way. But we have oral agents, including sulfonylureas, thiazolidinediones, SGLT2 inhibitors, DPP4 inhibitors. And then we have injectable agents, until now, all the GLP-1 receptor agonists and insulin. The 2019 ADA guidelines for second-line medication therapy after metformin have a bunch of options, and you'll see their kind of repetitive nature. An SGLT2 inhibitor or a GLP-1 for patients who have cardiovascular disease, an SGLT2 inhibitor followed by a GLP-1 for patients with heart failure or kidney disease, an SGLT2 inhibitor or a GLP-1 if you need to promote weight loss. If there's no cardiovascular disease or kidney disease and you need to minimize hypoglycemia, you can use any of the agents except a sulfonylurea. And then finally, if cost is a major issue, sulfonylurea or thiazolidinedione. Cost is a major issue. 2019 report from the CDC pointed out that 13% of adults didn't take medications as prescribed to try to reduce the cost of the medications, and 24% of patients asked their doctors for a lower cost medication. In talking to patients, this was reiterated to us, the financial toxicity. One older patient described working many hours per week to qualify for employer-based insurance. He was well past the age that most of us would think about retiring. The complexity of treatment regimens is difficult, particularly with complex insulin regimens. We heard about the stress of monitoring dietary intake and monitoring blood glucose, the discomfort of frequent glucose monitoring and of injections, the fear of organ damage from diabetes, and the pain of living with neuropathy. So the scope of this review is looking at a new oral GLP-1 receptor agonist, oral semaglutide. Injectable semaglutide has been available since 2017. Semaglutide is the first oral GLP-1. All the other classes for diabetes, with the exception of insulin that are commonly used, are oral. The comparison is with injectable GLP-1s, with SGLT2s, and with the DPP4 inhibitors. The specific ones we picked are driven by the trial, or the trials. There's a whole pioneer program studying oral semaglutide, and the comparators included, among the GLP-1s, liraglutide, not that commonly used a GLP-1 at this point because it requires daily injections, sitagliptin, a DPP4 inhibitor, and empagliflozin, an SGLT2 inhibitor, and to placebo. We have cardiovascular those are head-to-head trials. We have cardiovascular outcome trials of all the agents and also of injectable semaglutide. The cardiovascular outcome trial of oral semaglutide was short and only went 1.3 years. So again, we have head-to-head trials, and they're going to help us look at glycemic control, weight change, and adverse events. But for cardiovascular outcomes, we have these cardiovascular outcome trials for cardiac and cardiovascular outcomes. I'm saying cardiac there because heart failure is an outcome, renal outcomes. But to look at these, we're having to be indirect. Those were all against placebo. And so we're using network meta-analysis to try to compare those. I'm going to go through some of the results. You can see here that compared to liraglutide, reduction in A1C at 26 weeks is pretty similar with oral semaglutide. Oral semaglutide is better than empagliflozin at reducing A1C and better than sitagliptin. In terms of weight change, at 52 weeks, oral semaglutide was better than liraglutide, very similar to empagliflozin, and better than sitagliptin. In terms of the cardiovascular outcome trials, we have these, again, 1.3 year short oral semaglutide, 2.1 years actually relatively short injectable semaglutide, also smaller than the other cardiovascular outcome trials. And then you can see the numbers on the other trials, which were longer and bigger. This is 3-point MACE, major adverse cardiovascular events. So we're talking here about MI, stroke, and cardiovascular death. The first two lines there in gray are oral semaglutide and injectable semaglutide. And for our analysis, we combined those. Again, they were smallish trials, and we decided it was okay to combine them, and we'll come back to that issue. And you can see that semaglutide looks maybe better than empagliflozin, maybe better than liraglutide, and better than sitagliptin. On nephropathy, you're not seeing the two gray lines there because there was no nephropathy outcomes reported on oral semaglutide. This is injectable semaglutide. We're extrapolating. You can see that semaglutide and empagliflozin look pretty similar. There's a sense that the drugs like empagliflozin, the SGLT2 inhibitors, are probably better for nephropathy, but you can see that that's hard to tell there with wide confidence intervals, and maybe a little better than liraglutide. Sitagliptin isn't listed there because nobody thinks the DPP-4s are any good for nephropathy. Heart failure. You can see the huge confidence intervals for oral and injectable. When you combine them, there seems to be no effect on hospitalization for heart failure. Empagliflozin, the SGLT2 inhibitors, are good for heart failure, for preventing hospitalization for heart failure, and is clearly better than oral semaglutide. Liraglutide may be better than semaglutide, maybe the same. Again, wide confidence intervals. Sitagliptin, no effect on heart failure. So, limitations of this network meta-analysis. We have wide confidence intervals where small differences could be important. You would care about little differences in MACE that this indirect comparison isn't going to tell you so well. We combined oral and injectable semaglutide. That may or may not have been reasonable. You saw the way the forest plots, those individual numbers, looked up there, and except for heart failure, they looked like it was reasonable to combine them. And then the entry and exclusion criteria are not identical across the trials. People had different A1C levels, different baseline risk factors. With statins for cardiovascular outcomes, we've gotten used to the fact that there isn't a lot of effect modification. The reduction in events on a relative basis is very similar across different baseline risks. We don't really know that for diabetes treatments. So if we're combining them in this way, we're making the assumption that there isn't important effect modification. But there could be. It'd be better to have head-to-head trials. On quality of life and other patient-reported outcomes, there was variable recording across the trials, and there were no consistent quality of life benefits for semaglutide versus the other comparators. In terms of harms, GI side effects are really common with GLP-1s. Discontinuation for GI adverse effects was higher with semaglutide than for empagliflozin or sitagliptin. There may have been more adverse events related to diabetic retinopathy. There's some thought that if you quickly improve glucose, that may flare diabetic retinopathy. Hopefully we'll get better answers on that from larger trials that are coming. And then SGLT2 inhibitors increase the rates of minor genitourinary infections, particularly in women with yeast vaginitis and UTIs, and that can be a problem with them. In terms of controversies and uncertainties, I mentioned the imprecision in the NMA results, particularly comparing semaglutide and empagliflozin on the major adverse cardiovascular events and nephropathy. Do the comparators represent the underlying classes? We're sort of looking at these because this is what was studied, and for the most part, these were reasonable drugs to study, but you could ask whether they do represent the underlying classes. Adherence. In clinical trials, adherence is always better than in the real world, and semaglutide has lots of GI side effects. Additionally, oral semaglutide has this sort of complex initiation regimen where you start at a very low dose for a month, you go to an intermediate dose for another month, and then you decide to go up higher or not after that. And it has to be taken on an empty stomach. So it's possible that real-world adherence won't look as good for oral semaglutide as it looked in the clinical trials, and that's less of an issue for the other drugs that we're talking about. And then rare harms might affect decision making. And I mention this in part as a primary care doctor where I know that this is a concern among primary care doctors with the SGLT2 inhibitors, that there are these rare, horrific genitourinary infections, events of DKA, and some concerns about limb amputations that have people maybe nervous about that class of drugs and maybe patients nervous about that class of drugs out of proportion to how common those events are. And then there's a theoretical concern about thyroid tumors with GLP-1 receptor agonists. In terms of potential other benefits and contextual considerations, so having an oral GLP-1 is potentially a big deal. You don't have a pain of injection. You have a treatment for patients who refuse injections, and that's not uncommon in diabetes, to have patients who say, I'm okay taking oral stuff, but please don't give me insulin, please don't give me something injectable. And then it doesn't require refrigeration. Many of the injectable treatments do require refrigeration, and so if you think about travel and other issues, that's potentially important to have an oral drug. In terms of public comments received, we got a lot of public comments about real-world adherence, which I've mentioned to you. We got a lot of public comments about uncertainties in the results, which I've mentioned to you, and I think we've stressed it adequately in the report. And then in the cardiovascular outcomes trials, you saw how things lined up nicely on MACE there, but if you look at the individual components of MACE, they're all over the place different for oral and injectable. And again, that to us seemed like it was an effect of small numbers, but if you believe that really stroke is different and MI is different and cardiovascular death is different, they don't line up as well until you combine them all together like that. We thought averaging them together was the best thing to do. So in summary, comparing to an injectable GLP-1, which is obviously a big deal, we're talking about oral versus injectable, seems to reduce the A1C and weight loss more than liraglutide. The point estimate on MACE favored semaglutide, but with wide confidence intervals. We gave this a rating of promising but inconclusive. Against empagliflozin, in some ways perhaps the most important comparison, here a GLP-1 against an SGLT2, we thought that it reduced A1C more than empagliflozin. Both drugs had similar effects on weight. MACE reduction could have been better than empagliflozin, but with very wide confidence intervals. Empagliflozin reduces hospitalization for heart failure more than semaglutide. There's really no question about that. Both drugs seem to have similar effects on nephropathy, although the feeling on the class of drugs has been that maybe nephropathy prevention is better with the SGLT2s. Discontinuation was higher with semaglutide, and the GI side effects were much more common. And then you have these rare, severe genitourinary infections with empagliflozin that could affect patient decision-making. We rated this comparison I for insufficient. Against sitagliptin, oral semaglutide reduces A1C, weight, MACE, and probably nephropathy more than sitagliptin. Sitagliptin is better tolerated. We gave this a rating of B+, at least somewhat better, maybe a lot better. And then finally, against background therapy, reduces A1C, weight, MACE, probably nephropathy compared to continuing background therapy. We gave this an A for superior, clearly better. Questions? Jason?
David, thank you. Thank you so much. That was really, really informative and helpful. I had a question about how to properly interpret confidence intervals in the setting of a Bayesian network meta-analysis, and I'm really not sure about the answer.
And of course, I should be called incredible intervals since it is a Bayesian.
This is referent to slide 31, if it can be brought up. So in the comparison of semaglutide to empagliflozin, the difference in the effect estimates are based on a comparison of the two medications to standard therapies. So the effect estimates are distinguishable from one and different, but they're not different from each other because the confidence intervals overlap. So I mean, I know this isn't a direct comparison. The whole problem here is that we don't have head-to-head RCTs, right? So that's an issue we're going to have to discuss. But so how do we properly interpret whether there's actually a difference between the two medications in terms of the limitations of an NMA.
I think the limitations of the NMA and all the Bayesian ways, I mean, you can look at the credible intervals and get the same feel for it, but also we have the statistical effects from the NMA, is we're not sure.
Yeah.
You know, it certainly doesn't look like semaglutide is likely to be worse on MACE than empagliflozin, but whether it's better on MACE, I don't think we know that.
Yeah. Okay. That's helpful. Thank you.
Move this forward.
I also want to say thank you for that really helpful presentation. Is this one? Yeah. I was looking in the report, more specifically focusing on adverse effects related to discontinuation, and then looking at GI adverse effects. And I noticed that there were between 25 and 42% of people in the various different studies in the treatment group that had DC secondary to adverse effects that weren't GI. So I was curious what those were in general.
I think we have a table that gives all of them. Are you able to point to in the evidence summary where that is?
So, sorry. We don't have all of them listed in the report, but they are reported in trials, and I can pull those out. The majority of adverse events related to discontinuation were gastrointestinal. There are some others, and I can try to pull those out for you as well.
Okay, yeah, I would appreciate knowing like
sure
the
thing.
most common.
The other most common ones,
Yeah,
definitely,
thank
for
you
sure.
so much. And specifically leading to discontinuation.
Yes, definitely.
Thank you.
Quick question. What's the pathophysiological or whatever mechanical rationale for why semaglutide would be better than liraglutide?
I don't think there is one.
So some of the findings would seem to suggest that it's better.
Yeah,
It's not
it might be the
it's
dosing and the specific. I mean, you know,
Okay.
these are similar drugs. Obviously, the oral could have very different pharmacology. I think, although, as mentioned, although the trial was against injectable liraglutide, which is this daily injection, the drugs people really are wondering about it against would be injectable semaglutide and other weekly injectable GLP-1s. So I would view it as more reassuring that oral semaglutide isn't worse than the injectables, than that it's necessarily relevant that it might be better than liraglutide.
If I read the reports correctly, the GI side effects are worse with the oral than with the injectable. Is that correct?
I'm not sure that we can tell that for oral semaglutide versus injectable semaglutide from the information we have at this point. But oral semaglutide clearly has lots of GI side effects. There's no question about that.
Yeah, I think liraglutide is worse, injectable liraglutide is worse than injectable semaglutide. And in the comparison, I think oral semaglutide was worse than liraglutide. So that's not a direct comparison, but if you connect the dots, one might think it's worse.
I guess I'm very concerned about that in terms of compliance and real-world use. That's the issue.
I think that's a real concern.
This may be more important for the modeling piece, but I'm wondering how you interpreted the weight and blood pressure outcomes, given that the short period of the trials and the fact that blood pressure and weight, which is related to blood pressure, are sort of drivers of cardiovascular events. And, you know, just sort of thinking about whether you're actually seeing all of the benefits in the short period of time that the study went on.
I think we don't know, in terms of long-term cardiovascular benefits, how to think about particularly the SGLT2 inhibitors and the GLP-1s, since particularly around their weight benefits. First, do they maintain those over time? And second, what does that do for risk over time, since, as you suggest, weight is a risk for multiple things that we care about, including diabetes. And so that's why there's a lot of excitement about those two classes of drugs.
So the SGLT2 and GLP-1 have a little bit of a differential effect on blood pressure and weight. The GLP-1 we tend to think that their effect is on lowering blood pressure. As you see, they are more likely to decrease stroke when you look at the individual MACE. SGLT2 inhibitors do decrease weight and blood pressure, of course, but I think their effect on MACE is not related to the lowering of the blood pressure and the weight. Their effect is actually most of the MACE effect we see is from the heart failure, decrease in heart failure. We didn't see any decrease in MI or stroke with SGLT2 inhibitors. So I think looking at the long term, you can see in the short term weight and blood pressure decrease in both classes, but I don't think you can relate that one is causing the blood pressure lowering is not significantly associated with the lower MACE with the SGLT2 inhibitors. So what I'm trying to say that the GLP-1 receptor agonists have all decreased blood pressure and similarly at the same rate have decreased the stroke. So this is why in the longer term you would expect their effect on MACE to be more significant in that regard.
I want to come back to the adherence issue with a question for our clinical and patient experts. I'm trying to sort of think through how to balance out the GI side effect story, the issue about the complexity of the oral regimen, daily, empty stomach, and how that will, to some degree, surely, but the question is sort of how much blunt the potential advantages of an oral drug as opposed to an injectable formulation for those patients for whom an injection may not be desirable or preferable. I know we don't have data on that, but how do we help me think through how those advantages and disadvantages may balance out sort of the net benefits of this oral drug?
Yeah, I mean, I'll start, but I'm sure others have comments. I think it's going to be very patient-specific, and I think one of the things we learned with the GLP-1 agonists was that it's not just the injection per se, but it's also insulin. So patients very unwilling to take insulin are willing to take a GLP-1 agonist because I think there are a lot of other fears and myths associated with insulin. So that's one thing. Some patients, though, do still hate insulin, and that will be a big factor. My understanding, and this hasn't been brought up, but is that the pill is actually quite large. So for some patients, that's going to be a factor as well. And then the nausea is, in real world, just like in the trials, a big reason patients stop taking the medicine. And I would say, I mean, I don't know what there's post-marketing data, but probably about a quarter of patients just can't tolerate the GI side effects. So I think it's going to be a very individual thing for specific patients. That's my sense.
One thing I was thinking about in addition to other GI symptoms is that if there is a precipitous drop in blood glucose or hemoglobin A1C, we may also see some gastroparesis, which leads to other problems. I didn't necessarily read it in the literature, but that is something that happens when someone starts to take medication that they may not have taken before, and that leads to a whole host of other issues in terms of dietary facts that need to go into it. I am steering towards a person-centered approach to care, and I cringe just a little bit about the words compliance, control, and adherence, which is something we're trying to address a little bit more in the literature, because when people, especially with type 2 diabetes, hear those words, it leads to more reasons that they may just not go back for follow-up because they feel the blame, shame, and guilt that goes along with it. So just want to put that up front as well.
Just a quick, it's my experience that, for example, you put somebody on statin, they get muscle pain, and you really cannot convince them to try even a lower dose. With GLP-1, at least in my experience, they get GI side effect. I can convince them to re-challenge, and I'm still talking about injectable. I'm not talking about oral. So I wouldn't be surprised with oral if they get GI side effect to get re-challenged with an oral pill and go up titrate slowly.
I was just going to make one comment, switching hats to my primary care life, which is that I think sometimes the diabetes specialists are often seeing patients who are more willing to think about injections, and primary care doctors are often dealing with people before they're quite clear that they don't want injections of any sort, and so having an oral option is a big deal. The side effects are also a big deal.
We have time for one more question.
Just one question about the weight loss that we've seen together with the GI side effects. Do you think that, in fact, that people are just feeling more poorly and eating less and having more nausea, and that's what's causing the weight loss? I mean, is there, this isn't essential.
I've argued that that's how metformin works, but I'm wondering what you all think about the GLPs.
Right. I mean, I think that's definitely a component of it. I think there's thought that there are maybe other physiologic reasons as well, but there's no question that the nausea is likely part of why people lose weight.
So it's quality of life.
But I think I don't know. I don't think this was explicitly mentioned, but some of these drugs are FDA approved for weight loss, right? So the GLP ones.
I don't think I'm contradicting, but I just think that I think GLP-1 have shown A1C lowering regardless of the weight effect. Your question was if the nausea is causing the weight loss.
It's really a quality of life issue I was asking about. Are we seeing the weight loss because they're just feeling yucky?
I think because of the nausea and vomiting, whether that's yucky, patients who lose weight with diabetes actually feel very good too in other ways. Okay. So, yeah.
Fair enough.
But we have to admit that, I mean, GLP-1 do not work only, I mean, they have at least three different mechanisms they work. So it's true they slow the stomach emptying, and that's why they delay gastric emptying, and that's why they get the nausea. But they also increase insulin, decrease glucagon, and they work in the hypothalamus. So they have different way of working, and that's probably not the only way that's causing. Thank you.
Thanks. I'll turn this over to Greg Gazauskas.
Hi, I'm Greg Gazauskas. I'm a senior research scientist at the Comparative Health Outcomes Policy and Economics, or CHOICE Institute, in the Department of Pharmacy at the University of Washington. My colleague Ryan Hansen and I, we did the economic model for this topic, and other than the financial support that ICER provides to the University of Washington for the development of these models, we have no conflicts to disclose. Our objective was to estimate the lifetime cost effectiveness of oral semaglutide added to background treatment for the treatment of type 2 diabetes versus sitagliptin, empagliflozin, liraglutide, and ongoing background anti-hyperglycemic treatment alone. We developed a microsimulation adaptation of the UK prospective diabetes outcomes model 2 models, or otherwise known as the UK PDS OM2. Our population was type 2 diabetes patients with inadequately controlled HbA1c. We limited patients to those with an A1c of 7 or greater. The setting was the United States. We used a healthcare sector perspective. It was a lifetime time horizon in which we discounted all costs and outcomes by 3% per year. Our cycle length was one year each, and our primary outcomes were cost per quality adjusted life year, or QALY gained, cost per life year gained, and the cost per major adverse cardiovascular event, or MACE, avoided. So here's our model schematic. You've seen this in the report, and it's a lot of information that we tried to condense into a small package. And so what I'm going to do in 2 slides from now is give more of a demonstration of how the model is working in case this particular schematic was inadequate to convey what we did. Before I get to that demonstration, though, I feel it's important that we go over the UK PDS OM2 equations. And these were, the original version of this came out about 15 years ago, and then the equations were updated back in 2015. There are 13 type 2 diabetes complications equations, and these include heart failure, cardiovascular outcomes, renal outcomes, and then more microvascular outcomes such as foot ulcers and amputations that result from things like that. There are 4 mortality equations. They're mutually exclusive. I won't go into all of them in detail, but it's really about, did you have an event in the year that you died? Is your death due to that event? Did you die without an event? Did you die the year following the year that you had an event? That's what these equations are doing. And they are big regression equations that were developed to look at individual patient characteristics. And so that first bracket, the individual patient characteristics, is what I want everybody to focus on. We take the patient as they are, we apply the equations to them, and then annually we can predict what kind of outcomes they're going to have long term. So here's the microsimulation demonstration. On the left, we've got how we're tracking an individual patient in the model, and then on the right, we've got the microsimulation of each one of these diabetes complications. Just a quick note that each one of these complications has its own formula. So the patient enters the model. This patient is 55 years old, has a BMI of 34.6, and HbA1c of 8.5%, and thus far does not have any history of diabetes complications. And there are many more of these vital statistics and things that are in the model, but I've simplified it here just to keep it something that I can fit on the slide. So based on those patient characteristics, we run them through the complication equations, and we do a random draw. And in this year, the model predicts that this patient had an ulcer, a foot ulcer. So now we go back, and we've tracked the patient, and after 1 year in the model, they are 1 year older. Maybe their BMI and their HbA1c has creeped up a little bit, and now they have a history of ulcer. In subsequent years, now we're using the tracked patient to apply those to the UK-PDS OM2 equations. So we run the model for year 2 for this patient. We do another random draw, but this time there were no events that happened. We still go back to the tracked patient. We increase their age by a year. Maybe their BMI and their HbA1c has creeped up just a little bit more, but there's no additional history of events. Do the same thing in year 3. Now this patient has had a myocardial infarction, so we update the MI history. And then in year 4, this patient had another myocardial infarction, only this time it was a fatal MI. And so once the simulated patient the hypothetical simulated patient has died, the lifetime simulation for that patient ceases at that point. Now, along the way, we've been tracking also the patient's treatment cost, their complication cost, their survival and quality-adjusted survival, so we're applying utilities for each complication that occurs. And these are discounted life years and qualities that you're seeing here. But we've been tracking that all along. And at the end of each patient's life, we then tally up their total complications, their costs, their life years, their qualities. And then we add them to all the other simulated patients that we've already run through. So let's say this is the 6th patient that we've simulated. And for simplicity, let's just say that we're running a simulation of only 6 patients. So this was the last one that we had to run the simulation for. And we take the average over the entire population, and here's what we get for this treatment. Now, because it's run on random draws and because, we do this for all 5 of the comparators simultaneously, but then because we're having to do random draws each time, if you run one microsimulation versus another, the results are always going to be a little slightly different, so we have to run multiple runs. In this case, we did it 2,500 times, and if you do it enough times, you get a stable average estimate of each one of the results. Here are the patient characteristics, and we used the NHANES patient survey So this is a nationally representative survey of the United States. We had a larger sample, about 745 patients with diabetes that we were able to pull out of this. But once we limited the patients to those with an HbA1c of 7% or greater, this brought it down to 362 patients. Our patients were on average in their lower 60s. On average, they were obese with a BMI of 34.4, and their average HbA1c was 8.7%. And then there was a notable proportion of patients who had previous histories of cardiovascular and renal complications. Some of the key model assumptions that we made were that the incremental rate of MACE, heart failure, and kidney function decline is independent of patient characteristics, and that's because previous trials have shown that these are independent, so we had to make that assumption. We assumed that hazard ratio adjustment of the UK PDS OM2 risk estimates for MACE, heart failure, and kidney function decline, which are based on the network meta-analysis results that Dr. Rin just presented, was maintained over each patient's lifetime. And that's because we don't know how these are going to play out on these outcomes beyond what we were able to observe in the trial, so we assumed that the hazard ratio adjustments were maintained over the patient lifetime. Lastly, we assumed that patients who discontinue treatment and or reach HbA1c of 8.5% or above receive insulin therapy and no additional drugs were modeled. So we know that patients go through a treatment cascade according to the treatment algorithm, but we were concerned that by adding multiple subsequent treatments, we would muddy the comparison among the primary comparators. And so just to keep that isolated, the comparison that we wanted, we limited it to insulin therapy alone once patients discontinue. So this is a slide I've already shown, the UK PDS OM2 equations, and this is just to highlight that for these particular outcomes, for these particular equations, this is where we applied the network meta-analysis hazard ratios that were maintained over the patient lifetime. So here's the MACE hazard ratio as it played out in the model. So this is how the simulations played out. It's another way, I guess, of looking at the forest plot that Dr. Rin presented. And we would expect that oral semaglutide would have better MACE efficacy compared to background treatment alone. We would expect that liraglutide and sitagliptin would have similar efficacy in preventing MACE versus background treatment alone, not quite as good as oral semaglutide. And we would expect that sitagliptin would be about the same as background treatment alone. For heart failure, empagliflozin looks like we would expect it to have the best outcomes for heart failure prevention, followed by liraglutide, and then sitagliptin and oral semaglutide, roughly the same. Oral semaglutide a little more uncertain there, but roughly the same as background treatment alone. And then for renal outcome efficacy versus background treatment alone, oral semaglutide and empagliflozin were similar, although there's more uncertainty regarding the oral semaglutide. That's just reflecting the wider confidence interval there. And liraglutide also better than background treatment alone, and we just assumed, since we didn't have data for sitagliptin, that it was the same as background treatment alone. Here are the estimated treatment costs. For oral semaglutide, we have a wholesale acquisition cost, or WAC, per bottle for oral semaglutide, but we don't currently know what the discount from the WAC will be. And so we used the discount from the injectable form of oral semaglutide to estimate the net price per year for the oral semaglutide. And then we estimated a cost of $6,103 per year for oral semaglutide. Sitagliptin and empagliflozin were less expensive at $1,505 per year and $2,088 respectively. And then the most expensive treatment was liraglutide at $8,013 per year. So here are our estimated base case results. And as I'm going through the point estimates, hopefully you'll be able to follow along with the uncertainty that we've plotted above that shows some of the overlap of the outcomes and trying to get you to appreciate that the point estimate is the point estimate, but some of our results are more certain than others. So liraglutide was the most expensive at $305,000 for a lifetime of treatment, followed by oral semaglutide at $295,000. And then for QALYs, oral semaglutide had the highest QALYs at 4.03 QALYs, followed by empagliflozin at 3.97. And then sitagliptin and liraglutide and background treatment were less effective than those two. For life years gained, we saw similar life years gained for oral semaglutide and empagliflozin and liraglutide, whereas fewer life years gained for sitagliptin and background treatment alone. And then for MACE, oral semaglutide had the fewest MACE, and this is a 3-point MACE, but the results were, there's a lot more overlap in the results, probably due to all of the different types of MACE that were possible and how that was scrambled through in the UKPDS OM2 equations. Here are estimated base case incremental results. For cost per life year gained, oral semaglutide was potentially cost-effective versus sitagliptin at $80,000 per life year gained, was not cost-effective at $290,000 versus empagliflozin. It looks like it's cost-saving versus liraglutide and was potentially cost-effective versus background treatment at $70,000 per life year gained. For the cost per QALY gained versus sitagliptin, it was also potentially cost-effective, although closer to the $150,000 willingness to pay threshold at $140,000. Was not cost-effective versus empagliflozin at $480,000. Was still cost-effective versus liraglutide, and then versus background treatment alone, still an ICER under $150,000 per QALY, but more uncertain about that. Let's look at that last graph, if I can go back. So this is the same graph that's on the top right there, and I've expanded it here so we can see it a little better. So we've got a lot of certainty based on our results, and this is, again, based on the estimated cost of oral semaglutide. And I'll come back to that. But based on our price for oral semaglutide that we've estimated, we're pretty certain that it's going to be cost-effective or even cost-saving versus liraglutide at $100,000 and $150,000 cost per QALY. We're pretty certain also that it's not going to be cost-effective versus empagliflozin, at 3% probability of being cost-effective at $100,000 per QALY threshold, and only 8% at a $150,000 per QALY threshold. The things that we're less certain about are the comparisons versus sitagliptin and background treatment alone. So versus sitagliptin, there's 19% and 59% at 100,000 and 150,000 thresholds. And for background treatment alone, it's 34% and 83% of our simulations were cost-effective. We ran a number of scenario analyses. I'll only present these two for the sake of time. We did a modified societal perspective in which we used age and disease-specific productivity costs that were applied to each treatment arm, and unfortunately we were unable to identify as yet a way to tie those productivity costs to the events in the model. We're continuing to explore that. So these are just costs that were tacked on to patients who are still alive, basically. And this resulted in similar cost-effectiveness ratios once we ran the simulations, and that's because most of those costs are canceling out while patients are still alive, and so the only differences are the result of small overall survival differences among the different treatments. We also ran a scenario where because we had assumed that the treatment effects for MACE and renal effectiveness were maintained over a patient lifetime. We took a look at what happens if we reduce the efficacy of MACE and renal outcomes by 5% and by 10% each year. As you would expect, the cost-effectiveness ratios tended to increase because we're getting the drugs are losing in their effectiveness over time, and so the incremental qualities would be going down in that case. Some of our model limitations. The first is that we took diabetes is a very complicated disease, and we used the UK PDS OM2 equations, which are they're there to distill this very complicated disease into some mathematical formulas that try to approximate an actual lifetime of disease and disease complications. That said, it's been used for many years by many different groups and is continually validated. And it's the most used approach in the field of diabetes modeling. Our NHANES population may not be a perfect match for the pioneer trial populations. So that's a limitation. Our assumption about the trial outcomes lasting for long term, I've already mentioned that a few times. And then the treatment cascade, where we assumed that once a patient discontinues treatment, they go on to insulin instead of modeling all of those other downstream drugs that may muddy the comparison. We received a number of comments. The first is the patient cohort selection was not representative of the pioneer trials. I just went over that in the last slide. And while that may be true to some degree, the counter argument may be that any kind of trial population is not necessarily representative of the U.S. population at large. So we feel that the NHANES population was a good choice for our model. And we had the access to the patient-level data from NHANES, whereas we don't have the access to the pioneer trial patient-level data. The model outcomes we received comments that the model outcomes were lower or higher than expected. And there were indeed a number of fixes that we needed to put into the model. It's a complicated model, but we received a lot of great feedback, particularly from the manufacturers who we shared the model with and got their direct feedback. They got a copy of the model and were able to get their hands on it for a couple of weeks. And through that process, we fixed a number of problems, and the results now are more in line with what we would expect. And then the last comment would be that we're highlighting here is that the excessive amount of uncertainty, to which we think that's a feature, not a bug, as far as the report goes. We wanted to highlight that some of these results were highly uncertain. So the conclusions for oral semaglutide are that oral semaglutide has, on average, better outcomes than sitagliptin, similar health outcomes to empagliflozin, better health outcomes than liraglutide, and better outcomes than background treatment. For cost, and this is again based on the estimated cost of oral semaglutide using the net discount that we used from the injectable form. But based on the model, overall, oral semaglutide would be more costly than sitagliptin, more costly than empagliflozin, less costly than liraglutide, and more costly than background treatment. And then the takeaways are that oral semaglutide is potentially cost-effective versus sitagliptin and background treatment at a 100,000 to 150,000 per quality threshold. It's dominant versus liraglutide. That means it's cost-saving and gets better outcomes. And it's not cost-effective versus empagliflozin, and that's primarily due to the fact that it's much more expensive per year than empagliflozin. And just to stress one more time, all these results are dependent on our assumed price for oral semaglutide. Questions?
Thanks, Steve. First of all, I just wanted to congratulate you. I think it was literally the clearest explanation of microstimulation I've ever seen. So thank you so much. Yeah, a really complicated concept. You did a fantastic job.
Thank you.
I had a question about the assumption in the model that that events transitioning through a state where you have an event you made an assumption that it's independent of the patient characteristics. Was it also independent of the patient's history as they transition through the model? Like, I don't know if you do like tunnel states or how you could deal with that, but I would be concerned if you made the assumption that an ASCVD event would not be, the probability of transitioning through that state in a given year would not be conditional on the prior experience of that patient in the model having that event.
So the UK PDS equations are accounting for the patient history, and all we've done is applied the hazard ratios as an incremental difference among the treatment comparators for that. So we are...
So that addresses the concern.
Yeah, okay.
Thank you so much.
Kudos to you and Ryan. I think it was a terrific job. I really like the infographic with the different occupations, particularly the astronaut. I always wanted to be an astronaut.
I fought to keep that guy in there.
You don't see the astronauts represented much so anymore. My question is about the idea to model according to patients then moving on to insulin, irrespective of what treatment was being started. And my sense is that this biases the ICER estimate against semaglutide, and that a patient starting on empagliflozin or sitagliptin might be more likely to move to a GLP-1 after failing that than a GPL-1 patient may be more likely to move to insulin. And if that's the case, the higher cost GLP-1s versus insulin would bias the ICER estimate against semaglutide. So as a premise, does that make sense, and is that something that you considered in a scenario analysis?
Yeah, I think that does make sense. We did not consider it in a scenario, mostly because we were focused on that head-to-head comparison. And if you start throwing in a treatment cascade, as many diabetes models have had to do, because that's reality, you suddenly end up in a place where, yes, you may have a patient go onto a GLP, and then maybe another GLP or a DPP-4 or insulin. And so to try and recreate that reality and then roll back to the ultimate question we were trying to answer, it just was, I think, an impossible task.
To answer that additionally, I think the first question we were trying to answer was, do we have concerns that oral might not be as good as injectable? Once we were past that, really there's this question of GLP-1 or SGLT2. And you could imagine a pathway starting next with GLP-1, then an SGLT2, then insulin, or SGLT2, GLP-1, and then insulin. But both of those are pretty likely to become important pathways in the management. And so I'm not sure that I agree that it biases it against the GLP-1s.
Greg, could you just go back to the previous slide? So we list here among the health outcomes that OS is superior to liraglutide. And in our evidence ratings, we are saying that the evidence is promising but inconclusive. Are you summarizing this on the basis of modeling results and not taking into account that trial evidence? Or, in other words, is this independent of that?
Well, you mean the model results are based on the evidence and the evidence synthesis. And this is a very simple distillation, really showing that overall, on average, oral semaglutide had more QALYs versus the comparators, or similar QALYs. And I think I illustrated before that there's overlap. You know, there are some simulations where even background therapy may do better than some of the others. So Yeah, those arrows are just a distillation of these point estimates.
Sure. I think that despite our highest uncertainty against empagliflozin, the probabilistic sensitivity analyses show that over a range of believable outcome numbers, it is still the case that oral semaglutide is very unlikely to be cost effective. If the question, so that we would have a lot of trouble answering which one is clinically better right now. But if that estimated net price is true, the PSA tells us, even though we're not perfectly sure which is better, it's very unlikely that oral semaglutide is enough better to make up for the very large difference in cost.
Yeah, I was just pointing to the health outcome side, irrespective of cost. And so just trying to reconcile our promising but inconclusive evidence rating with the conclusion that it's superior.
We rated it, I think there you're looking at the point estimates in that. And I think that there is important uncertainty there. We have cardiovascular outcomes trials that overlap, and the point estimates from there don't give you a perfect answer to that.
And also, I think you were showing it was broken down by the type of cardiovascular or renal outcome, right, for those ratings, whereas the QALY is more of a summary of all of those things coming together in the model.
I wanted to ask about the scenario in which you assumed that there were declining MACE and renal effectiveness. I was thinking a little bit more along the lines that it might go the other direction, that there were improvements in lipid profiles, there were improvements in blood pressures, there was improvements in weight, and all of those I would expect to enhance the effectiveness over time. So I was curious why that might not have been a scenario that you chose to analyze.
We isolated it to just these hazard ratios. Now we do model changes in weight and A1C over time. That's based on an algorithm from a different source. I didn't have time to present it in this presentation, but we actually modeled that HbA1c and weight tended to increase over time. We modeled the initial improvement in year 1, and I think we maintained it until year 2, after which point we assumed that it creeped up a little bit. And then for any of the other vitals, we mostly didn't have a way of modeling that long term that we were able to identify, so we just kept them constant throughout the patient's lifetime. Clearly, their blood pressure and things like that would change over time, but that wasn't something that we were able to tackle.
Can I add something? I think I have a comment, but I forgot to mention something. Sorry, I apologize. I have a disclosure. I did a one-time consulting this past summer for Novo Nordisk about educational content. It was a one-time thing, so I will update the report with this disclosure. Going back to your comment, I think it's important, the point he's bringing up, that A1C definitely has, you're taking that into account, but definitely A1C is not the major thing that's going to increase costs with time. I mean, definitely correlation with microvascular complication, but when it comes to MACE, probably the worsening of the kidney function and the blood pressure and so on have more likely to have an effect on MACE. However, in both directions, I think whether it's SGLT2 or GLP-1, we do know that they're going to probably have a beneficial effect on the kidney function similar to the blood pressure.
So I have 2 questions, probably more for our experts here. How often do you have a diabetic patient that cannot really put on empagliflozin? Is it a common occurrence because of candida infections, or you're afraid that the patient is going to be dehydrated? Is it common that you just have to avoid that medication or not?
Is the question how frequently we have to avoid the medication
Yeah,
or stop it?
empagliflozin is not an option for a patient.
I think, in my opinion, there's really not a lot of contraindication with empagliflozin. Of course, advanced heart failure sometimes. I tend to use it more. The guidelines do recommend to prioritize SGLT2 inhibitors in patients with heart failure. And I do want to mention that we're talking about heart failure with reduced ejection fraction because we still have hope that GLP-1 might have a better benefit on heart failure with a preserved ejection fraction. We don't know. We have studies in both classes. But in general, if there is really no major contraindication for SGLT2 or patient, even if they have urine or yeast infection, or some people have incontinence, as soon as you tell them that this medication is going to cause some polyuria maybe, or increase urine, or they tend to say, no, I don't want more of that. Regardless, it's not something that they will avoid just because of this concern specifically. Now, another SGLT2 inhibitor, we have a concern with peripheral vascular disease, and that's canagliflozin, but this did not translate more into other SGLT2 inhibitors. The other concern is that patient who there's a concern of diabetic ketoacidosis. So sometimes patients who are using insulin with type 2 diabetes, which is a lot of them, at least that I see, we tend to be more cautious about how to prescribe SGLT2 inhibitor, but definitely, again, not a contraindication for that. It's just more caution on how to prevent or how to look for signs of diabetic ketoacidosis.
Yeah, I very much agree with what was said. The one comment I would make, especially about the yeast infections, and I think on an earlier call you mentioned this, like I have a colleague who says that minor surgery is surgery on someone else. And it was commented that these were minor genitourinary infections. When women especially get the yeast infections, it is very common to say, I will not touch that drug again. They're very severe, and the rates of those are pretty high. With respect to the amputation risk, what I see a lot of is patients have seen the ads on TV about that by lawyers, and so they won't take the medicine because of those ads. While there is one study out of Sweden or Denmark from a big registry that suggests that it may be a class effect and not a single drug, but that was kind of a post-treatment. So I think that amputation thing is still a little up in the air. Whether it's real or not, patients are getting the TV ads, and so that limits them taking it.
Thank you. We have time for one more question. Martha?
I have a question about the disutilities, and I'm wondering how much the QALY piece sort of figures into how you created the QALYs. I'm looking at your table 4.6, and I just was struck, and I wanted to ask the clinicians here. I see that you used the health utility index and from a sample of people. But I was amazed that a myocardial infarction event had a similar disutility to an incident of hypoglycemia. And I just sort of wonder about whether enough credit is being given to the disutility of certain events and how that might affect the sort of QALY formation.
Sure. So don't think of those as disutilities as much as those are like full regression equations for calculating an individual person's utility. So you have to take all of the coefficients into effect to get to an individual patient. So I don't really think of them, we spent a lot of time as a team talking about this. We don't really think of them as disutilities per se, because you've got to take an entire patient's characteristics to calculate the difference between one person with an MI, say, or
but still the order of magnitude, I guess,
Yeah.
is what I'm sort of questioning. However you use that,
Sure.
it just seemed, it didn't seem clinically sensible to me. So and I wondered, if in fact you had a lot of a decrease in MIs, whether that wouldn't have a much sort of grander effect on your QALYs than a few hypoglycemic. I don't mean to trivialize hypoglycemic episodes, but I just think an MI is a big event.
No, it's a fair comment, yeah.
Okay. So at this point, we'll transition to our manufacturer comments and discussion. I'd like to invite the manufacturer commenters to the lead table here, please. And as